All right, let's jump straight into the clinical pathophysiology of the acute multiple sclerosis exacerbation. We're bypassing all the basic definitions today because we need to construct a high-level clinical framework, one that's calibrated specifically for advanced assessment. Precision is absolutely paramount here. You have to be able to seamlessly delineate between an acute attack, disease progression, and the downstream symptomatic fallout.
The exact clinical signature we're analyzing is the acute degradation of the myelin sheath. This inflammatory breach typically presents in young women, usually in their 20s to 40s, and it manifests as highly discrete focal deficits. Think of classic presentations like optic neuritis bringing on painful vision loss, or internuclear ophthalmoplegia progressively developing over a matter of days. And interestingly, while we often think of MS as purely a white matter disease, gray matter is actually heavily involved early on too. But it's really those subacute demyelinating lesions, the ones heavily associated with classic oligoclonal bands in the CSF, that truly drive these acute relapses.
Now, when you're observing acute spatial dissemination on a high-contrast FLAIR MRI, you'll see these incredibly luminescent, contrast-enhancing lesions that correlate perfectly with an active inflammatory cascade literally breaching the blood-brain barrier. We're talking about those classic pericallosal ovoid lesions, the famous Dawson fingers, named after the Scottish pathologist James Walker Dawson, who first described them over a century ago. They orient completely perpendicular to the ventricles, and remember, if these lesions enhance with contrast, that is your definitive marker that the plaque is active and subacute, typically meaning it's under 60 days old.
So the spatial dissemination drives wildly different yet highly testable focal deficits. Take a brainstem lesion driving internuclear ophthalmoplegia, or INO. This stems directly from a highly specific lesion right in the medial longitudinal fasciculus. If the patient attempts a lateral gaze, the affected eye completely fails to adduct, and you'll see this fast-beating nystagmus in the abducting eye. Contrast that specific presentation with the patchy, eccentric spinal cord inflammation we see in transverse myelitis. The precise anatomical location strictly dictates the clinical reality.
When you're facing these acute deficits, the therapeutic sequence is absolute. If a patient is actively deteriorating with a flare, your immediate reflex must be high-dose IV corticosteroids, specifically IV methylprednisolone for 3 to 5 days. But what happens if that flare is entirely unresponsive to the steroid pulse? Well, the strictly required escalation is plasmapheresis, or plasma exchange. You literally have to go in and mechanically filter out those offending autoantibodies and inflammatory cytokines.
All right, let's shift gears from acute rescue to chronic disease modification, effectively building out our progression shield, because once the acute flare is handled, the clinical objective completely changes. Historically, our first-line agents were classical modulators, things like interferon beta and glatiramer acetate. And sure, while they boast a minimal side effect profile, they just simply cannot match the raw efficacy of modern targeted monoclonals, like ocrelizumab.
Ocrelizumab is a highly efficacious modern biologic that hones right in on the CD20 receptor, and it aggressively depletes circulating B cells. By halting their ability to present antigens to T cells within the CNS, this maintenance therapy dramatically reduces relapse rates and slows disability accumulation. But, and this is a massive caveat, it does absolutely nothing for an acute active flare. It is a progression shield for sure, but it's not a rescue medication.
Beyond the acute and chronic phases, we have to handle the massive downstream symptomatic fallout, which requires precise pharmacological alignment. For instance, severe upper motor neuron spasticity driving painful muscular destruction strictly mandates a central GABA-B agonist like baclofen or an alpha-2 agonist like tizanidine. In cases of autonomic dropout resulting in a hyperreflexic bladder, while halting that detrusor overactivity strictly demands a muscarinic antagonist like oxybutynin. Conversely, if you're dealing with a flaccid bladder, that requires a cholinergic agonist like bethricol. So here is the definitive rule for your clinical variants. You simply cannot cross these management streams. A patient presenting with new-onset painful vision loss due to an active plaque strictly requires IV corticosteroids. But a patient sitting in the clinic just looking to prevent future vision loss, they strictly require a disease-modifying therapy, like ocrelizumab. Attempting to treat an acute exacerbation with a chronic disease modifier or vice versa is a profound failure of clinical understanding.
Okay, we're going to stress test this exact knowledge right now by mapping out the blueprint for a master-level clinical assessment. We are going to integrate an acute MS exacerbation with a masked, therapy-resistant trajectory to simulate a true 270-level clinical trap. Our patient profile is a 28-year-old female with known MS. She presents to the ED with 3 days of profound bilateral lower extremity weakness and a clear T4 sensory level on her exam.
Following the standard of care, she's immediately admitted and treated with high-dose IV methylprednisolone for 5 days. But, despite this aggressive intervention, her symptoms relentlessly worsen, and she's now completely incontinent of urine. Here is the real diagnostic trap. The vignette explicitly provides her outpatient medication list, showing she's highly compliant with daily ocrelizumab and baclofen. By embedding her chronic meds right after the primary acute therapy fails, the assessment heavily tempts you to inappropriately alter her chronic or symptomatic therapy. The prompt strictly demands the most appropriate next step in medical management for her current hospitalization.
Under actual exam conditions, facing these highly competitive options, you have to forcefully separate acute rescue from chronic maintenance. So what's the next step? Do you add a second biologic like alemtuzumab, increase the dose of ocrelizumab, maybe transition to an oral prednisone taper, initiate plasmapheresis, or do you increase baclofen and add oxybutynin? You must recognize the failure of the initial intervention and identify the exact next acute therapeutic tier.
Let's deconstruct these diagnostic traps choice by choice. Plasmapheresis? That is the correct answer. It's the absolute mandate for a steroid-refractory acute inflammatory breach. Adding alemtuzumab or increasing ocrelizumab? That's crossing the streams. You never use a progression shield to treat an active exacerbation. Transitioning to an oral prednisone taper is wildly incorrect. If high-dose IV pulse steroids have already failed, a step-down oral taper absolutely will not arrest that destructive cascade. And while increasing baclofen and adding oxybutynin does address the symptomatic fallout, it completely ignores the active, ongoing inflammatory destruction of her spinal cord.
I really hope this explainer has sharpened your clinical framework. The distinction between an active inflammatory breach, chronic disease progression, and secondary symptomatic fallout isn't just some academic exercise. It dictates every single pharmacologic intervention you make. When you're standing at the bedside of a rapidly deteriorating patient, how will you ensure your acute, life-saving interventions never become entangled with your chronic maintenance matrix? Keep your therapeutic pathways distinct, and remember, never cross the stream.